Thank you. I'm Jules. I am a long-term employee, first-time speaker. I've been working at Eye Specialist for 12 years now, and I can say, hand on heart, it's a beautiful place. Everyone from admin to clinic to the doctors, are all there for the right reasons, and we're very empathetic and compassionate about eye care. So, Ravi, I'll talk to you tomorrow about pay rise. Okay. So I'll start off with our costings. Obviously, cataract surgery is the number one surgery that we perform at our clinic. So we're going to start off with, we've got two sort of fees. So we do a pre-operative fee, so when the patient first arrives, and what that includes is the cataract clinic workup, which can be up to half an hour consultation with one of our clinical members, including myself. And that will also include their surgical preparation pack, which I'll show you guys through later, and also the consultation with one of the doctors as well. So for a private patient, it's a measly $550 out of pocket, and pensioners only $300. So good. For the surgery costs.
I just want to say one thing. The other thing is that it's an outpatient charge, so they may already qualify for other rebates just because of the Medicare safety net.
That's right. Once they hit their safety net, they will get more money back. So total bargain. For our surgeon fees, if you're insured, there is no out-of-pocket at all. We will take whatever their health fund offers. And then if you are uninsured, for one eye is $850 out of pocket, $1,175 for bilateral cataract surgery. Of course, there's the anaesthetist and hospital fees too. And as far as I'm concerned, it is a total bargain. So we'll just go through what's included. So we started doing this pre-cataract clinic about 12 months ago. And so what happens is patients will call up and they'll say, I've got cataracts, so our admin staff will book them into the cataract clinic. So at that appointment, they'll come in, they'll just see us clinical staff, and we'll do their initial measurements and we'll give them their little show bag that they get to take home. On the second appointment is when we'll do the biometry. We'll dilate them at that appointment. So the first appointment, they can just drive themselves. Second appointment, bring someone, bring your hat, bring your sunnies. And of course, they'll meet the ophthalmologist who, on that day, because we've done all of the tests, it's just a quick appointment, in and out. We'll just wait for their dilation and then they're on their way. So why did we start doing it like this? The main thing was poor ocular surface. So we hate that as the clinic. It's hardcore. So I'll get into that after. Secondly, obviously it's a better patient experience because they have the time in that consultation with us. We just covered the basics, so nothing technical, but it's that basic stuff like, when can I go swimming? When can I play lawn bowls? When can I wash my hair again? All of that. If I've got all those questions, that's what we go over. And then of course it does definitely result in more reliable surgical outcomes. So for the first visit, we do all of this in that half an hour consultation. So we do a basic explanation of what cataracts are. I know that all you guys tell them what a cataract is, but pretty much everyone comes in and they go, it's just scraping the front of the eye, isn't it? It's easy. And we're like, oh, not quite. So we sort of go through that so they understand why they've come in and they've got to do this myriad of testing. So we will do that, then we'll check their vision, corrected and uncorrected. We'll do their ocular dominance, so that comes in if you want to do a mini monovision or a monovision correction. Pressure, we'll do the autorefract to measure their glasses. We'll do their basic retina check, so OCT of macula and disc. We'll do their topography. We want to know how much astigmatism they've got, if there's any irregularities in their corneas. And we'll also do their tear film breakup time on the topographer as well. On their first visit, we will give them info about an eye stent or the other procedure that we can do for implants and pressure. So we're pretty much just looking at if patient has already been diagnosed with glaucoma, or if they've got a family history of glaucoma, or if their pressures are over 20, then we'll just sort of flag that there is an extra option that doctor might think is worthwhile doing at the same time as their cataract surgery. If we do the tear film breakup and it's less than 7 seconds, then we will sort of contact Caitlin on the day and say, look, I think it's probably worthwhile for them to go through our dry eye clinic on site and do an assessment, and we'll figure out what the issues are there. And then if necessary, you know, it's eye drops, it's plugs, it's IPL if necessary. And we want to get that all sort of sorted out before we go ahead with cataract surgery. Now, at this first visit still we're on, they get to take home some goodies. So, of course, we just give them some handouts and their homework. So we give them the Ransco cataract surgery brochure. We give them a list of sort of all the frequently asked questions, and we'll give them the eye stent brochure if they need that too. So that just gives them the time then to read through, have a think, and then when they come back in 2 weeks' time, they've got the opportunity, if anything's missed on our handouts or they think of anything else, then they can have their little list of questions. So when they come on their second visit, they're ready to go. Okay, so our pack that we give out is this little show bag here. So this is the game changer. This is what makes things so much easier for us when we're doing our measurements. So we send them home with a warm compress eye mask. So it's just a microwave thing, and they pop that one on once a day. Usually at night we say, treat yourself for a couple of weeks. Before they do that, we'll say give your eyelids a wash. So we'll give them the foam or lid wipes. And of course, preservative-free lubricating drops. So we'll get them to use these at least 4 times a day leading up to their biometry measurements. Ping. Okay, so 2 weeks later, they will come back with these beautiful, moisturised, lovely ocular surface eyes. So at the second visit, we're straight up doing their biometry. So before we had this sort of dry eye, essentially their pre-operative appointment, I was constantly faced with these horrible keratometry IOL measurements, and I was quite often sort of doing this scenario where, because patients would get quite concerned, they're like, what's wrong? You know, am I doing something wrong? Is there something wrong with my eye? And I just sort of say, well, with a beautiful, lovely ocular surface, you know, it's much like the first image where you can see that nice reflection coming off the nice, calm, still water. And there I was, this dry as the Sahara, and we're not seeing any sort of mountain whatsoever. So, I mean, we could calm them down, but it's just a stress that they don't need, because they're thinking, oh my gosh, they're not getting my measurements. I'm going to end up with the wrong lens. I'm not going to get a great outcome. So that has really helped in that situation. The other thing that you guys probably relate to is you may have the dreams or nightmares of 1, 2, 1, 2, 3, 4, 1, 2, 3, 4. My nightmares were blink, blink, fluttery blink, blink again, blink, blink, squeezy blink, squeeze, no, not your pelvic floors, Mavis, your lid, squeeze, squeeze it, squeeze, squeeze. It was just constant. So now I don't have to do that. So we're all happier in the clinic and we're getting better outcomes. So I'm just going to show you what our actual sort of, when you have dry eye or an unhealthy ocular surface, you sort of get these dancing mires, and they disappear and they move around and they get small and they get big, and that makes me want to vomit. I don't like those. So with our 2 weeks of lubrication and intensive, tear film production, we don't get that. We get perfectly still, perfectly crisp every time. So it just makes things much more reliable. Unfortunately, I was forced under duress to continue this talk about post-operative drops. So that's what we'll just quickly go over now. So I know it's very boring. So I've just added puppies into it, which has come from the 378 Cutest Puppies website. So we'll start with cataracts and refractive lens exchange. So we're going to do Maxidex for those patients 4 times a day for 4 weeks. Siloxane until the bottle is empty, which is usually about 2 weeks. And of course, preservative-free artificial tears. So we ramp it up quite a lot after surgery. So it's 4 times a day up to a month beforehand. And then for the first 2 weeks, we'll do it every 1 to 2 hours, and then 4 times a day for 2 weeks. And that's just alleviating all of the, oh, my vision's blurry on and off. It's sort of it's fluctuating. My eyes feel gritty. We just don't get any of that anymore. Oh my gosh, thank you. Next is corneal grafts. Siloxane 4 times a day until the bottle's empty. We're going to go do Maxidex 4 times a day until we sort of, depending on how it's going, Ravi will sort of then taper down as we go, as it's healing. Obviously, preservative-free artificial tears again, 4 times a day for a little while, and then it's usually an ongoing thing for comfort as well. Pigtails! Oh. All right, pterygium and limbal tumours. So Chlorcig 4 times a day for a week, Maxidex 2 hourly for a week, and then 4 times a day for 4 to 6 weeks, depending on healing. And those lubes again. Now, if it comes back that the patient does have a limbal tumour, CIN, about 3 months usually, we will then put them on a course of mitomycin C eye drops that we get compounded for the patient. So it's 4 times a day. At the moment, it's generally 4 times a day for a week and then a week off, and then we do 3 cycles of that.
Jules,
yes.
the steroids, you have to take them or just stop?
They just stop, actually. I don't know why. Look at that. I love him too. Okay, so for our Presbyon LASIK smile, we give them a little minims of oxy to take home. And we just say use it 1 hour post-operatively and as you need it. So they obviously don't have a big amount, and we don't get patients that call that need any extra. We also prescribe oral pain relief. They've got Siloxane 4 times a day until the bottle's empty, Maxidex 4 times a day until empty, and then of course our tears 1 to 2 hours. Winston. All right. So corneal cross-linking, PRK, PTK are all the same. So once again, they get their oxy. We do send them home with about 2, a little bit more, because this one is a little bit more uncomfortable. Siloxane until empty, T drops 1 to 2 hours. Acular is 4 times a day until their contact lens is removed a week later. FML until the contact lens is removed. And then once the contact lens is out, we'll start them on Maxidex, and that's going to go 4 times a day for 4 weeks, and then we do taper that one 3, 2, 1 weekly. I'm highly allergic to dogs, so I need to just admire from afar. Now, obviously what's important with all these drops, there's obviously multiple drops at a time, so it doesn't matter what order the patient does the drops, but we just want them to, give them a few minutes in between each so that you're not sort of essentially washing it away with the second drop, third drop. And that's the end. Thank you.